Good afternoon, everyone. This is Marissa Tonelli. I am the Senior Capacity Building Manager at HealthHIV, and I'm very excited to bring to you our second webinar in our Sync webinar series titled Sync or Swim, and we'll be discussing strategies for AIDS service organizations and community-based organizations navigating a dynamic healthcare environment. And this is going to be an ongoing series of webinars. Many of you may have attended our first webinar series last month. This is a monthly webinar series that we'll be hosting leading up to next year's Synchronicity National Conference in April 2018. So today I just wanted to point out a couple of housekeeping things. We will have slides available throughout the webinar. They're PDF'd in the bottom right-hand corner of your Webinado screen. There's a document folder. If you click on that document folder, you can download different items that are available right now. We are also recording this webinar, so if you have to hop off or you would like to listen to it again later on or share with a colleague, it will be recorded and shared on HealthHIV's website, and the link is there, healthhiv.org/resources. And we'll be hopefully have some time for Q&A at the end of it, but if not, we'll make sure we post some Q&A questions and responses on our website as well. Along with questions, you can use the chat box at the bottom left of your screen. It is public. Everyone will see the questions, so you can chat to any of our presenters. We'll be taking questions at the end just to make sure we get through all the content, but feel free to interact with us and with one another throughout the event. And if you have any questions about audio or anything, please let us know using the chat box as well. So our learning objectives for today are to discuss how healthcare reform is impacting ASO and CBO sustainability and HIV, hepatitis C, and LGBT services delivery, to talk about strategies for improving organizational sustainability and impact through partnership development, review key elements of fiscal sustainability and revenue diversification to enhance vitality of programs, and describe how we can use leadership and governance to better engage in strategy development and decision making. So again, I'm Marissa Tonelli with HealthHIV. I'm pleased to be joined today by Emily Hirio from Project Inform. She's the Director of State and Federal Affairs. We also have Shana Linov. She's our Fiscal Training Specialist at HealthHIV to talk about fiscal components. And lastly, we have Scott Bertani, who's the Director of Policy at Lifelong AIDS Alliance, who's going to talk about his experience as an ASO leader and decision maker within his organization and some of the adaptations they have made internally. So without further ado, I'm going to turn it over to Emily, who's going to do a brief overview of some of the healthcare reform impacts and discuss some of the hot topics today around legislation and funding. So Emily?
Thanks, Marissa. You can hear me, yeah?
You're great.
Okay, great. So thanks everyone for having me. Good morning to those of you on the West Coast like me, and good afternoon, and also good morning if there's anyone from Hawaii or Alaska, and then good afternoon to the rest of you. So I'm going to cover some of the most concerning developments taking place at the federal level that could impact your organizations and the people you serve. And first, I'll talk about some potential cuts to health and social service programs. Second, I'll talk about efforts to repeal and replace the Patient Protection and Affordable Care Act, also known as the ACA, also known as Obamacare, which may be especially critical to those of you who work in organizations that bill Medicaid, whether that's for primary care or substance use services or mental health services. And third, I'll talk about some suggestions of things that you and your organizations can do to respond to these federal threats. So the first thing, and then, I just want to give the caveat here that, this is all very fast changing. There's a lot that could change in the next few days, in the next few weeks, in the next few months. So just keep that in mind, that none of this is sort of set in stone, and this is a really dynamic set of issues. So the first thing I'll talk about is potential cuts to health and social service programs. And as many of you probably know, the president proposed to cut about $1 billion from domestic HIV programs in his fiscal year 2018 budget. And that includes cuts to HIV prevention programs at CDC, including $149 million or 19% reduction overall, and that includes the HIV school health program. Also, in the Health Resources Services Administration, or HRSA, proposed elimination of the AIDS education training centers, which are funded through a part of the Ryan White program, as well as a proposal to eliminate the SPINS projects, the special projects of national significance. So in the president's budget, those two things would be eliminated completely. With a proposal to eliminate the Secretary of Health and Human Services Minority AIDS Initiative Fund, as well as the Substance Abuse and Mental Health Services Administration Minority AIDS Initiative, cutting that about $18 million. And we know that those funds often go to do innovative programs to serve, Black, Latino, Native American communities that are impacted disproportionately by HIV, and in the SAMHSA program to really help address the intersection with substance use and other behavioral health concerns. A proposal to cut HOPWA, Housing Opportunities for Persons with AIDS, within the Housing and Urban Development Department. The proposal is to cut that $26 million or 7%. Proposals to cut almost 20% of the HIV AIDS research at the National Institutes of Health. In addition, related to HIV, cuts to CDC's STD prevention programs by $22 million, elimination of the Teen Pregnancy Prevention Program, and while the president's budget proposes maintaining other parts of Ryan White and other parts of CDC that might be relevant to us, like the viral hepatitis division of viral hepatitis. These programs are flat funded in the president's budget, and really, given recent challenges, demand increases in order to be effective, and that's true across all these areas. That really we should be looking at increases rather than decreases. The sort of silver lining there, I would say, is that in general, the president's budget, regardless of who the president is, the president's budget is usually a suggestion, and Congress very rarely maintains sort of the president's proposals. So I'll talk a little bit more about what you can do in response to the president's budget at the end. And then the bigger chunk, I think that, even more discouraging piece to talk about is around attempts to repeal and replace the Affordable Care Act. So I'll talk about the Senate's version of what the House was calling the American Health Care Act. In the Senate, it's called the Better Care Reconciliation Act. I would say both of these acts lack a lot of health care, so it's sort of funny that care is in both of their titles. And again, with this in particular, a lot could change between me talking right now and what happens when the Senate comes back from their 4th of July recess. So I would take everything I'm saying with that note. But based on what we do know, this bill from the Senate is bad for almost everyone, and it's especially bad for people with chronic conditions, people who are older, people with HIV, hepatitis C, people impacted by the opioid crisis, LGBT people, and basically everyone, all of us work with and care about. The Congressional Budget Office, or CBO, estimates that over 10 years, this bill would cause 22 million people to lose their health insurance. And the Center for American Progress estimates that if this bill were to pass, it would cause 217,000 more people to die by 2026 than would be expected under current law. It would cut about $772 billion from the Medicaid program, along with additional reductions over time based on rate of inflation that's used in the bill. And it would repeal taxes among the wealthiest Americans and health insurance companies, and those taxes total about $541 billion. So I think the biggest concern is the cuts to the Medicaid program. By 2026, it's estimated that 15 million people would lose their Medicaid coverage. I won't go into the details about the financing and why it would cause that drop. I can get into that in the Q&A if people are interested, but for sake of time, just note that the estimate from the CBO is about 15 million people would lose Medicaid coverage by 2026. And this also affects not just the lowest income Americans who use Medicaid, but also middle-class Americans who rely on some of the services that Medicaid programs provide that are optional services that states can readily limit in response to federal funding cuts. So that includes nursing care for seniors, in-home support services for seniors and adults with disabilities, and special care for children who have particular healthcare needs. And so those services are likely to be slashed by state Medicaid programs if they're dealing with budget hits, because those are optional services that they're not required by federal law to provide. And in terms of, our concerns with HIV and aging, I think this is particularly relevant. Another critical piece is that states could apply for waivers to get rid of the essential health benefits, which are currently required of almost all health plans in the United States. And that covers a number of things, but some highlights of essential health benefits are things like maternity and newborn care, mental health and substance use services, prescription drugs, laboratory services, preventive services. There are some others. So a state could apply to get rid of these essential health benefits in their marketplace plans and in other plans in the individual market. And prior to the requirement for having essential health benefits, 45% of plans did not cover inpatient or outpatient substance use disorder services, and 75% of these are non-group market plans. 75% did not cover maternity care. So you can see, the shift kind of back to that would be likely if states were allowed to waive that requirement. This bill could also lead to the return of annual and lifetime limits, which we know for people with chronic conditions like HIV or hepatitis C or cancers, getting to the lifetime limit can happen fairly quickly. Coverage for transition-related care would be decimated by this act. There would be concerns about coverage for birth control and other pre-existing conditions. And of course, HIV and hepatitis certainly fall under pre-existing conditions. The bill would also get rid of the individual mandate, which requires everyone to have health insurance or face a tax penalty. And it replaces that with a requirement to maintain continuous coverage. So anyone who applies for insurance in the individual market would be forced to wait 6 months for their coverage to begin if they had a gap in insurance of more than 63 days in the prior year. And we know a lot of the folks we work with often experience gaps in coverage. So this could make acquiring health insurance difficult for them. There's a lot more I could say. I know I'm short on time, so let me get to some other quick highlights. Just that Planned Parenthood in this bill would be defunded for 1 year. And so that is certainly a concern because we know Planned Parenthood in many communities provides HIV testing and drug treatment and linkage to drug treatment and hepatitis C testing and other important services. So for a year, Planned Parenthood wouldn't be allowed to access Medicaid funding, and that could destroy Medicaid in many states, or Planned Parenthood in many states. There are a number of senators who are concerned about this, including Republican senators that we want to reach out to. So if you're in Kentucky or Nevada, West Virginia, Arizona, Colorado, Alaska, Ohio, Maine, Wisconsin, Utah, Louisiana, I would say those are some key states where we want to make sure the Republican senators hear from people about this Healthcare Act and that, people are very concerned and don't want to see the ACA repealed. The the head of the Senate, Mitch McConnell, wants to try to get a revised bill to the Congressional Budget Office by tomorrow. We'll see what happens there. He's probably going to make some concessions to try to get some of the moderate Republicans to support this bill. He has about $200 billion to work with in a slush fund. So you may see him trying to make compromises like putting funding into the opioid crisis or putting funding to support health savings accounts to try to appeal to the conservatives that aren't on board either. So look out for those kinds of things. Really briefly, what you can do around the potential budget cuts proposed in the president's budget is make sure your members of Congress know that you oppose cuts to health and social service programs, provide examples of why robust support is helpful, what, things from your own programs or individuals you serve. Regarding healthcare, Families USA has a ton of great resources. If you click on their website, familiesusa.org, they have a section called Initiatives and then Protect Our Care. And that helps you figure out how to connect to your senators to call. Attend town halls. The senators will be on recess for the 4th of July, so there may be Independence Day parades or other events where they'll be in attendance next week. So try to go to them and make your voice heard. Go to their district offices, the senators' district offices, or help organize events in front of their district offices. And the messaging really needs to be that we oppose any proposals that would increase the number of people without health insurance or cut Medicaid funding. And it's really important they hear from us that, we want them to oppose any bill that would increase the number of people without health insurance, that those are sort of the basic requirements. So I know I went a little over time and I'm very sorry. So I can stay on towards the end if there are questions. I know that this is a moving target and a lot to talk about, so I'm happy to clarify anything at the end.
Great. Thank you so much, Emily. I know it's a lot, and I think there will be some questions, and I'm reading the chat box of everybody kind of chiming in and commenting on how we need to work together. So please utilize the resources again. You can download the slides. The links are there, and Emily will be on towards the end if you have specific questions. And HealthHIV and many other organizations are doing their best to kind of collect all of the potential challenges and changes that could be upcoming. But as Emily mentioned, it's very much up in the air at this point, and all we can do is really work together to advocate to Republican senators primarily not to move forward with the new health care bill. So I'm going to take that moment to transition into our next slide presentation. Again, I'm going to be talking specifically about strategic partnerships around organizational sustainability and go back a little bit to what Emily said and how that kind of ties into what ASOs and CBOs are facing right now. So what I wanted to share just to start is how some organizations have traditionally defined success and sustainability. So they looked at sustainability as continuing their organization, sustaining niche providers offering single or few services, being able to employ their staff, having a modest net income or only a modest deficit, or having a slowly improving financial situation, or more invested leadership or board of directors. But what really we want to look at right now, especially with the very dynamic healthcare landscape, is moving from beyond this financial crisis to stability. So looking at sustainability as the ability to maintain and grow also our operations, services, and benefits, and also retaining and engaging the best and the brightest staff, and overall reducing new infections, improving the length and quality of life for people living with HIV as well and Hep C. So this is just another way of looking at success and measuring our success. So there are a lot of drivers to strategic partnerships, and Emily kind of highlighted some of these with the very changing healthcare landscape and policy. We know we're going to be faced with a reduction and possibly redirection of federal and state funding. With the changes in the healthcare system, there's enhanced integration of medical and public health systems, more focus on quality, collaborative, and accountable care models. And Emily mentioned healthcare reform implementation, which is another driver. And internally, as organizations, there are other kind of rationale for strategic partnerships. So long-term financial strength, the potential for public and or private revenue to increase with partnerships, the potential for staff retention to improve with increased revenue, and also the ability for staff to start to work on other projects and improve staff morale overall, the need for increased services to meet the needs of our clients, so behavioral health services, substance use services, the demand for more integrated care, and ultimately improved health outcomes are all driving kind of internally why we are seeking strategic partnerships as ASOs. So in terms of identifying areas for strategic partnerships, one of the strategies that we recommend is looking at kind of the market analysis or an environmental analysis. So looking at where there are gaps in services, where they're doing a client needs assessment or something of that sort. Some examples might be more of our clients are being diagnosed with hepatitis C. We might see a need for more culturally competent health services, LGBT health-focused services, or transportation as examples. And then the other piece to look at is where is there likely to be new funding coming down the pike. So we know that some of the prevention services are at risk with new funding, but we know that care coordination and any other services that remove barriers to medical care and also primary care are likely to continue to be funded and also continue to be supported by insurance. So mental health and substance use services, medical transportation for non-HIV clients and HIV clients, STI testing treatment, other chronic disease management, and telemedicine are all examples of where we might see new funding opportunities and are currently seeing new funding opportunities. And I wanted to point out something that HealthHIV put together several years ago. It's also available for download, our service collaboration matrix, which is a way to look at services that are provided primarily to people living with HIV and at risk for HIV, and mapping where your organization is either delivering the service or partnering with another organization to deliver the service or intends to deliver the service down the road. So it's a great exercise to go through internally, and we recommend that you take a look at it and download it and share it with some of your staff. I wanted to point out one example of kind of approaching strategic partnerships, and this is from Whitman Walker Health. They're a health center based in Washington, D.C. And part of how they move forward with developing some strategic partnerships with community-based organizations in the area was to think about what external services are critical to the Whitman Walker Health patients that they weren't already delivering. So they looked at this collaboration matrix and realized they probably needed to do home-delivered meals, needed better community-based re-engagement efforts, and also more early intervention services. So that helped them narrow down potential partners. And then they also looked at what populations were better connected or represented externally. So what populations were they not reaching as successfully through re-engagement or engagement efforts, and where could they work with other external partners to do so. So they recognized the need to strengthen their engagement of women, drug users, sex workers, and recently incarcerated. So those all played a role in how they identified their partners. And then also partnerships as improving clinical health outcomes. So we know as a whole, a community-wide medical home, particularly one that raises the strengths of partner organizations and makes the provider a much broader entity rather than a single entity. A single organization is much better equipped to retain and engage patients given its varied and vast cultural sensitivities. So we know extending the safety net beyond one care provider into the community and connectivity into the community can ultimately improve health outcomes. So back to my example, one of the examples with Whitman Walker Health is that they were able to partner with CBOs to get more information about clients, better understand the client's life outside of the medical record, so their barriers to care, their patient strengths, and also have a shared responsibility for caring for the patient, and better understand the support that wraps around the patient. So ultimately, this partnership really helped develop more robust care plans for all the clients that were shared between the two organizations. And it also helped the health center to really appreciate and better understand the skills and the reach of the community-based organizations that they were working with, which was important as well. So there are a variety of types of strategic partnerships. We're being brief today, so I'm only going to hit on a couple specifically, but a contractual arrangement might include a variety of models. So it might be a merger or an acquisition, or it might be a strategic alliance, which looks more like co-location of services, so one organization co-locating in another for a period of time, a purchase of services agreement where you purchase services for a fee, so a fee-for-service arrangement, or a sub-recipient arrangement where you both apply to a grant together and one's a prime and one's a sub-recipient in that model. So there's a variety of models, but I'm going to talk just very quickly about kind of the strategic alliance versus a merger. So we know a strategic alliance really, it's an overarching contractual agreement between organizations. It's not the same as an MOU or MOA. It's connecting interests of one organization to another to provide services. So it's a contractual agreement, usually tied to funding, tied to money, so there's funding exchanged. And the benefits of a strategic alliance is that you can maintain organizational autonomy. It certainly can be undone relatively easily. It may support one specific project or one specific initiative, and also will enhance clinical outcomes. The risks on the other side is that you might have a lack of follow-through by one partner or waning commitment over time because it might be tied to one specific program or project. You also are risking your reputation and funding because you're tying yourself to another organization, and it could potentially be costly administratively to maintain over time. And on the other side is a merger. So we know mergers, formal arrangements when two organizations combine into a single entity. And the benefits here are you have a very seamless integration of services, a reduction in redundancy of services. So it's not duplicative, it's holistic care, and also a continuance of services that might otherwise be closed. There might be more expansion opportunities with two organizations combining into a single entity. And you might improve the cost effectiveness, so having only one administrative center that's being supported by your organization versus two. The risks are the upfront costs, so developing the contract and making the arrangement happen. Cultural issues that might come up between organizations. It requires buy-in at all levels, which could be a challenge. And there could be a loss of financial and community support with a merger. It also might not work. So these are just a couple of things to keep in mind. And I wanted to point out one in particular as we're talking about improving health outcomes as a rationale and a reason for moving forward with a merger or strategic alliance. This is one example from Center Project when it merged with the AIDS Resource Center of Wisconsin, ARCW, and they're based in Green Bay, and they were able to increase the amount of services that they were providing by moving into this strategic merger with ARCW, and ultimately actually grew as ARCW grew. So the community was then able to offer the organization offer services to the Green Bay community that included pharmacy, medical clinic, dental clinic, mental health, and a drug treatment program. So all services that ultimately helped improve outcomes for their clients. So some brief lessons learned I just wanted to point out. We know partnerships take time, so it's important to start building those relationships today. It's important to do your research. Some partnerships that make sense on paper don't ultimately work out. There are organizational culture differences that are too much to overcome at times. And sometimes it just comes down to how engaged or responsive an organization is to move the process forward. We also note that frank discussions really need to happen with organizational leaders about past history and perceptions. And there's a culture adjustment for moving from years or decades of competing for funding, the same funding sometimes, to having to work together. And it takes an immense culture shift to do that. We also know that you have to keep in mind no organizations are set up the same. You can't expect them to be. Some staff spend more time in the community, like a community-based organization. Others spend more time at their desks and expect real-time updates, which isn't realistic. With sharing of data, with sharing of EMRs, which has happened in some alliances as well as some mergers. There are IT challenges that come up that we have to be patient with. And then one kind of on the side of finances and reporting, we know that we have to ensure that it is a mutually beneficial arrangement. And there can be a lot of tension when one organization, if it's a health center or another larger aid service organization, holds the funding, and the other organization feels like they're waiting to kind of receive the funding or in less control of that partnership. So these are all things to keep in mind. Obviously, with reporting for two organizations versus one, a timeline needs to be adjusted. So avoid building resentment by keeping communication and appreciation flowing, and ultimately trust on the underlying relationship and your goal of supporting the shared clients. One note that we've heard from health centers partnering with community-based organizations is that not only for the community-based organizations do they have the benefit of adding patient care services, but they might also have access to capacity building for quality assurance, data analysts or financial experts or legal experts that they didn't before. So it's great to take advantage of that. And also noting that this might not replace the long-standing MOUs or relationships that you have outside of it, but can build on that. And the last point is that real-time bidirectional access to client data and information is essential, especially for improving health outcomes as a result of these partnerships. So I wanted to point out just a couple things before I turn it over to Shana, and that's some resources in TA that's available related to this topic. HealthHIV offers a Remaining Relevant in the New Reality training, which is a sustainability training for ASOs and CBOs. And one of the content areas that we focus on is identifying and developing strategic alliances and collaborative partnerships. We also talk about readiness for change and leading change, which can be a very important piece to keep in mind throughout a partnership development process. Business planning, practice transformation, and data sharing. So if you're interested in remaining relevant, it's a regional training, you can contact me. More information is also available at the link on this slide. And lastly, our ASO CBO Leadership Initiative has a couple of activities that are ongoing. We have a certificate program that's 6 modules. And if you're interested in becoming a certified ASO leader, there's a free program online you can access using this URL. And we also have a webinar series that goes along with the online self-paced modules. And this webinar series will be continuing throughout this year. Here are just a variety of topics, but we have many webinars archived on HealthHIV's website that you can go back and access as well. And our initiative is also launching a State of ASO and CBO survey. It's launching next month in July to look at kind of where ASOs and CBOs are at in providing services, what their needs are, and better understand some of the transformations they've been making over the past few years as a result of the changing landscape. So with that, I will turn it over to Shana. We'll hold questions to the end. And I thank you guys very much for listening to me.
Thanks, Marissa, and thank you, Emily. I noticed a few comments toward the beginning of the webinar mentioned that we might be feeling a little bit depressed listening to some of the updates that Emily had. So hopefully these strategies and resources will give you a little bit more hope. And another point, if you're not able to access the slides through the folder icon at the bottom right of your screen, you can provide your email and we will send them out to you afterwards, but they should be available there. We've been covering some strategies for navigating this dynamic healthcare environment. There's been a lot of changes, and so fiscal sustainability has become a big concern for a lot of healthcare agencies, and income diversification is a big part of that. I know Marissa mentioned strategic partnerships as well are important, and so that's another component of sustainability planning. And this part of the session will go more into the key components of revenue generation and income diversification. So these first couple questions will frame the discussion about sustainability planning and income diversification. First, if you think about what happens when funding gets cut from your agency or your program, if you have a large grant that's ending soon or is being cut, how will you maintain your services for your constituents or your consumers? How will you maintain the core or daily operations at your agency? These are a lot of questions that come up and concerns that a lot of agencies have as they're looking ahead to these funding changes and changing priorities in funding. So one of the first main components to think about is staying on your organization's mission. A lot of organizations that stray from their mission fail, and they may do this in order to increase or maintain cash flow, but this can be dangerous in that the mission really drives the organization's programming. And if the funding doesn't match the staff capacity or the need of the constituents, programs can be less sustainable. So pursuing new funding should involve strategic decisions to ensure that the funding is in line with the organization's mission, and whether this is grant funding or fee-for-service opportunities, determining whether it's in line with staff capacity and skills will really keep the organization most sustainable. And do these funding opportunities address the identified need that your program addresses? Another key component is that the internal stakeholders are key to ensuring sustainability of the agency. Everyone in the organization needs to be at the table when it comes to sustainability planning, and this is often left to the program director or development position or an ED to make decisions regarding this topic, but everyone should have a role. And for the board of directors, who has a direct role in ensuring sustainability, they can assess current sources of revenue and what the reliability of a certain single funding sources. They can also connect the organization to external resources. They can help develop and approve a budget. Same goes for the executive director. They can determine opportunities to expand revenue sources. They can think about the internal opportunities and use of resources and skills internally to maximize their staff capacity. They can also introduce the organization to potential or prospective funders. Management and frontline staff are also a key component to sustainability in that they are often responsible for meeting service delivery goals and objectives, and collecting data to demonstrate outcomes and performance. And of course, constituents are directly impacted by the sustainability of programs as well. So all staff should be engaged in sustainability discussions and organizational development and decisions around new revenue generation. So healthcare nonprofits need to be able to adapt their revenue models to the changing funding priorities. And there has been a greater emphasis, as we've heard, on moving away from grant-based funding, especially at the federal level, which is based on being paid X amount to perform a service, and moving toward more fee-for-service or performance-based funding, so being paid for a unit of service or being paid a higher amount for better service. So the first thing that needs to happen when transitioning to these other types of revenue models is to calculate the actual unit cost for the service you provide. And a lot of agencies don't know what it costs to provide a service or whether they break even based on their current funding structures, such as on a grant. So if an agency is going to be paid to perform a service based on a per unit basis, it's important to be able to quantify the resources, supplies, and staff time that goes into that unit of service. So thinking about what's being invested in that service in order to really maximize future funding. And for, depending on what setting you work in, for a clinical setting, this might mean that ensuring that all of your billable services are actually directed to a third party. So having the infrastructure available to bill Medicaid, and for those clients who are not supported by Medicaid, being able to bill other insurance or third party payers. And thinking of grant funds as a backfill for services that are not billable or payable by another source. In some cases, this might mean credentialing more employees and improving your medical documentation. So to answer the question of really what does fiscal diversification mean, it's to be able to leverage your new revenue sources to be able to advance the mission of your organization, ensure that all of the intended services are being provided to your consumers. This kind of ties back to the example of third-party billing and thinking of grant awards as a means to providing services and supporting your organization's efforts in doing so. As Marissa has outlined for us, that developing partnerships is another way to expand your service delivery or reach, as long as that stays in line with your mission. Also, focusing on performance measures and outcomes is important, not just the specific number of people served or reached, but considering how new funding can support your own performance goals and objectives. And of course, the role of leadership is important in promoting fiscal diversification really as a team effort. And the last main point that I want to make about the components of sustainability is that developing a culture of sustainability within your organization is really important. And what that means is that we need to move away from the culture that a grant drives programming, and instead focus on the idea that the organization drives the programming and that the grant fills in what we want to accomplish as an organization. So this means really setting organizational performance measures and goals and objectives, and approaching revenue generation as a support to the organization's mission. So just to summarize those points before we move into Scott's presentation, staying on mission is important just to maintain the viability of your organization. Sustainability is everybody's business in the organization, including the constituents. So everyone has a role in sustainability planning. Playing to your organization's strengths is important, especially in partnership development. So leveraging the resources and staff capacity that you have, being able to calculate unit costs in order to maximize funding opportunities and reach your break-even point. And lastly, that the organization drives the performance and programming, and that culture shift is going to be really important, ensuring that your program is viable. So with that, again, HealthHIV, if you are interested in learning more about these, the more specific parts of these strategies, since this was kind of a high-level overview of it, HealthHIV has a fiscal training program called Fiscal Health which covers a few of the topics listed here. We do technical assistance and group level training. So if you're interested in those for your agency, you can contact me or visit our website for more information about that. So now I will turn it over to Scott, who will be able to speak to a more on-the-ground implementation perspective of these strategies.
Hey, well, thank you very much. I am here to talk a bit about how sector transformation competition between ASOs brought about a formal strategic alliance, specifically with Lifelong AIDS Alliance and Evergreen Wellness Advocates in Northwest Washington, and how that joint venture in care coordination ultimately became a merge that also brought about some new business development opportunities, how it succeeded with the populations we served, and how it actually caused some challenges and interesting unintended consequences based on the evolving ACA and state healthcare landscapes. So, the two agencies that we're looking at basically are Lifelong AIDS Alliance and Evergreen Wellness Advocates. And these were basically formed through years of regional HIV service delivery with geographically distinct and population-level health attributes in Western Washington. So these are the two agencies. Currently today, Lifelong serves 12 Northwest Washington counties, and we provide medical case management, outreach and prevention, lots of HOPWA contracts with competitive and non-competitive grant pieces, some food security with our Chicken Soup Brigade division, dental and oral health, and some insurance navigation pass-through pieces. And we serve roughly about 3,000 clients and some 1,000 high acuity, high risk negative through our counseling and testing efforts and our PrEP-DAP program, as well as about 1,000 long-term support services Medicaid clients, which are chronic care condition disease state clients that are not HIV positive. I do want to mention that Lifelong is kind of unique in who it contracts out with. We are not formally contracted out with HRSA for medical case management. And this is part of the story of this. Back in about 2014, the administrative burden, obviously with HRSA and the issues with respect to clinical supervision became just, well, it came too much for our ASOs in the region. We unified under one banner, petitioned our senators and our Hill members, and said that we decline HRSA funding. And many of our Part C clinics had begun to do the same thing because we got some new project officers, and interpretation of how Ryan White should be implemented in our state was radically different than some of the things that we had done in the past, things in the past that had actually worked. So through that, we worked to flip the system such that the medical case management was taken on then by our Department of Health through General Fund State, and all those extra resource monies then went back into HRSA through the non-medical case management component and the essential support services, some of the dental, the food issues, the substance abuse aspects, and then it worked relatively well, but it took a lot of effort into it, and it was primarily because of the changing landscape of the ACA and actually some interesting things that happened in the state legislature for us literally around the exact same moment. So I just briefly want to talk about, for us, what sector transformation was. In light of the ACA, for us, it was the need for aid service organizations and community-based organizations to restructure how we provide those services, either direct or indirect, to better serve our clients and adapt to changes in the care and prevention funding opportunities world. In reality, it actually meant something much more profoundly expensive, but yet rewarding. So first, I would like to talk a little bit about our early adoption strategies, right? So every ASO during 2010 had the opportunity to take a step back and look at itself and think of three ways, right? We could either grow our businesses, we could either go, meaning go out of business, or we could cannibalize each other with some of the competition. And we first started down that road from that perspective. And for us, all of our AIDS service organizations in our region were really hungry for new businesses, but we just didn't know how to actually work together because so often competition will actually bring about some of that cannibalization that I was talking about. So the history of our two agencies have really been inextricably linked, and so too of our case management and prevention services. So where Lifelong served the main epicenters within King County, which was primarily Seattle, and the other Evergreen, which served the rest of Western Washington, with the exception of service delivery in Pierce County, which is Seattle's sister city, Tacoma. Now, within our respective territories, both Lifelong and Evergreen had always worked to enhance the other's programs through linkages and referrals and cross-cutting HRSA and DOH contracts. And because of those mutually inclusive service alignments in support of our local and regional HIV community, competition was rarely the soup du jour. But with the passage of the ACA in 2010 and the state's own legislative consolidation of administrative services for AIDS grants later that same year, well, the coziness of our ASOs relationship began to fundamentally change course. Suddenly, we seemed to get hungry for the other's scopes of work, each believing the other was better placed in this new era of expanded Medicaid, which Washington took on. So this long-term programmatic fine-tuning affecting the HIV prevention and care continuum quite regrettably caught many smaller agencies really ill-prepared for the shifting sands beneath, especially when it concerned lower prevalent counties. Others, like ourselves, preferred cannibalizing each other's contracts over coalescing at first. So prior to 2010, those contracts were awarded and administered by the lead agency in the largest counties based on the number of AIDS cases. But with the state legislature's passage of EHB 2360 in March 2010, by law, the AIDS net system was eliminated, and with it, the centralized position of regional coordinators, administrators who monitor the financing, the planning, and the capacity building to those agencies who hold the prevention and care contracts. And like a tip at the end of a good meal, those administrators took a sizable chunk out of available direct source funding right off the top. So when that bill passed, that lazy Susan approach to HIV service delivery moved from AIDS nets to our Department of Health planning, and it radically transformed the role of care and prevention for the largest AIDS service organizations in our region, opening up new areas of business development, like at the same time at the ACA. So to maximize service delivery to constituents in an era of diminishing resources, a polite way of saying cash poor, our Department of Health decided to reframe the governmental public health response to HIV and AIDS to more effectively serve its at-risk populations. So in essence, many local agencies and health departments serving lower prevalent counties lost their DOH fundable capacity to do care, to do outreach and prevention. But these cost-saving measures, they were implemented so that DOH could more effectively target state resources to support HIV prevention efforts in local health jurisdictions that had the greatest disease burden. But to keep some semblance and continuity of care and prevention regions going, DOH set out to differentiate funding allocations by HIV prevalence. As such, DOH correctly surmised that there really was only one high prevalent and incident county in the state, and that was King County, which is Seattle. And that accounts for probably about 65 to 70% of all persons living with HIV and AIDS statewide. They later segmented the outreach into mid-prevalent counties and listed them by rank order. So once they figured out where the disease was, they took a further step back and noticed another glaring obvious. The rest of Washington's 29 counties combined for only 6.5% of all individuals living with HIV and AIDS incidence and prevalence. So in layman terms, no prevalence, even lower incidence. So it only stood to reason that in an era of diminishing resources, those 29 counties wouldn't be receiving any care or prevention monies whatsoever. DOH, however, continued to support case finding and care efforts statewide through local health departments, through testing and partner services, and continuation, obviously, of the Ryan White Parts A, B, C, and D programs. So as you can probably guess what happens next, the cozy relationship of Lifelong and Evergreen as Ryan White dinner companions, well, it faltered when the itemized check came late in 2010 with all of these bill passages. The issue was a request for proposal for the county that stood in between our two service categories, which was Snohomish County, and that's the third highest in prevalence and incidence in our state. Those contracts didn't last long. Evergreen and Lifelong both made a pitch for it, and by 3 points, Lifelong beat Evergreen out. But about 2 years later, Evergreen then bested Lifelong after a series of care connection mishaps and contracts compliance issues. So I mentioned all this background of how Lifelong and Evergreen began the slow, independent dance towards developing a requisite leadership and governance to engage in sustainability through lots of mutually beneficial projects. Let's move on. So, well, the ACA, it definitely brought a banquet for many, and for us, it was either a big bite or cannibalizing. So the evolution and evaluation of how care and prevention services in Washington are performed allowed agencies like Lifelong and Evergreen to rethink about how our appetites for new business altogether was. The ACA, as we all know, it revolutionized the way we provide and pay for health care in the U.S., and that's essential that ASOs and CBOs funded by Ryan programs, that they seek out new innovative ways to diversify funding and service portfolios. So it makes us better equipped to monitor and evaluate current programs and demonstrate impact on clinical and non-clinical indicators. There are numerous benefits, obviously, to the ACA for Lifelong and Evergreen, but the two have important links to our work with at-risk HIV-negative persons and persons living with HIV and AIDS. First, the ACA was instrumental in increasing the number of individuals insured. In fact, in Washington state, about 700,000 Washingtonians enrolled in expanded Medicaid, and of those 700,000, there were roughly about 3,500 that were HIV positive. What that did was that freed up our ADAP, outpatient ambulatory care services, to have opportunities to other different types of programs through some of those 340B rebate dollars or pharmacy rebate dollars. Second, obviously, the ACA worked to help reduce costs for healthcare by developing new payment and service delivery models that, according to the Centers for Medicare and Medicaid Innovation, it achieves better care for patients, better health for communities, and lower costs through improvements to our healthcare systems. And that's how we entered the HIV-negative care coordination world with all that background. So, WACARE. WACARE is the Washington Care Coordination Services Group, and it was a group of nonprofit agencies comprised of the 4 largest ASOs in the state, which was Lifelong, Evergreen, Pierce County AIDS Foundation in Tacoma, and Spokane AIDS Network in Spokane. We all joined together in this new landscape to make an impact on the health of our communities, but also on the health of the communities that were beyond the HIV and AIDS world, thinking that we could really use lots of ways to capitalize on the work that we have done for many, many years. So once Evergreen in that Snohomish County really began to capitalize on its mission in Snohomish County by improving on the work that Lifelong really began and then lost that work, we began to directly compete with Lifelong for its clients in King County, believing that we were more seasoned, we were better equipped, and we were hungrier for that matter. And by competing, I actually mean siphoning off clients, setting up shop in Seattle doctors' offices, specialty pharmacies, clinics, anywhere Lifelong wasn't working to engage with its harder-to-reach clients. In retrospect, it was more like dinner on Lifelong's dime. I've obviously got some mixed feelings on how we went about that, but what competition actually did was bring us closer together in both physical proximity of services and eventually in the sharing of resources. Competition actually made Lifelong get better and Evergreen more diversified. So when the state's healthcare authority began looking for partners for its HealthHIV demonstration project, we knew we had to overlook each other's table manners and played up on a joint venture. Alone, we realized that none of us had the heft to successfully bid on HealthHIV subcontracts with lead entities, the likes of Optum or Molina or Amerigroup or Community Health Plan of Washington, big lead entities. What we needed was a statewide entity that could challenge for-profit healthcare consortiums and managed care groups to really prove our ASO salt, to demonstrate that our unique brands of case management and prevention services learned over 36 years of service, they were better situated than other agencies just entering the case management fray who were trolling for quick dinners. So So when Lifelong got a new ED after the Snohomish County contract loss, we began preliminary truce talks in order to form an LLC care coordination group called WACare. And it was the eventual first step to seeing if merging really made sense. Through WACare, Lifelong, along with its partners, well, we seized on the opportunity to finally engage in third-party billing that was really, for the first time, not dependent on Ryan White, Department of Health, or other discretionary or public health funding, or so we thought. So Health Homes, to give you some background into health homes and care coordination, health homes are not really a place. They're a set of services that support eligible clients, including helping, finding, and getting long-term support services. A lot like medical case management, but for chronic care condition disease individuals who are not HIV positive, who often have really the highest of the high acuity, who are often not getting better. And what we try to do is reduce recidivism rates of hospital readmission by entering into care coordination and medical case management contracts. So eligible members, they're passively enrolled in the program and receive a letter from the HCA that gives them the option to opt out if they don't wish to participate. And we, as designated care coordinators, would actually cold call them up and try to sign them up for services. Something completely different, cold calling. In the Ryan White world, obviously, people are coming to us for services. In this regard, with the health homes, we're actually seeking individual out to sign them up for case management. Generally speaking, WACare was a care coordination venture that tested the boundaries of ASO service delivery with other similarly known chronic care condition populations, much like our own HIV clientele. The problem being is that this population, unlike Ryan White, like I said, they had no frame of reference to what case management actually was. So when we cold called them up, cold call, we often got a lot of hang-ups, and our charge was to get at least 40% enrollment of the referrals that individuals brought to us, those lead entities that I mentioned earlier, like Amerigroup and Optum and Molina. Their interests were to subcontract out to us to hurry up to get comprehensive case management so that they could then reduce hospital readmissions, but they were also obviously taking a big chunk, just like the AIDS Nets regions had done previously. So Lifelong, together with its partners, we worked collaboratively together. We shared resources, staff, profits, and clinical expertise to provide in-home care coordination for an additional 2,000 statewide WACare clients. It was a huge, massive ramp up to be able to do this. And think about it, care coordination in the home for non-HIV positive, high acuity clients. Clients, many who had never spoken to a clinician outside of their specialty care doc or their ER doc on identifying and meeting client-centered goals. Like, how cool is that? Outside of the Ryan White world, case management, let alone medical case management, well, it's unheard of. We brought that. That is until the reimbursement model under lead entities became no longer sustainable, and lead entities decided they could best make more profit by doing it themselves rather than sub it out, so they cut us out often. While the model had proven somewhat unsustainable, we demonstrated over time a 6% reduction in hospital readmissions to the healthcare authority for those 2,000 statewide clients. And because of that work, many of the vendors we work with saw opportunities to partner with us later on other collaborative projects that were often more lucrative and better suited to our style of medical case management and prevention services without the burden of enrollment modeling projections, like duplicative data entry and care systems, or to learn or conversate about profit margins, things that ultimately cost us, not our lead entities. While ultimately we weren't in the health home game anymore, not entirely because of the reimbursement model, although it proved more resource intensive than originally thought, we were able to vastly expand our core competencies to populations that we knew needed our help, and we realized that we were stronger together than we were apart. We began to seek out contracts that were more aligned with our skill sets and our staff's interests. Because of all that work with WACare, there became a seat at the table for everyone at this dinner, at least in Western Washington. And because of that, we merged into a larger statewide entity that now serves over 12 counties. And because of this, we got a new contract through the Healthcare Authority to have an additional 1,000 clients for its long-term support services Medicaid transformation waiver. But most importantly, it told us that we need to sit down and conduct focus groups with our core clients. And all of the conversations that come out of strategic planning and joint projects and conversations with the Department of Health and the governor and the Secretary of Health and health jurisdictions and public health officers, all those things, it really just strengthened us. And we learned a lot, although really lock hair cost us a lot of money. But what we learned was we were able to fine-tune our skills, our core competencies, and ultimately we learned that in Western Washington, merging with other entities, it's a good thing. And with that, that's my end.
Great. Thank you so much, Scott. That was a great story to tell, and we really appreciated all the information. I know we're a little bit over time.
Yeah, sorry about that.
Had a lot. No, that's not your fault. All of us had a little bit extra to say. So I'm really happy to see a lot of people stayed on for the whole webinar and through the little extra minutes. So that's a testament to the important information and also to Scott, your great story. So thank you again. I'm going to move forward. We're going to just go through very quickly a couple more slides, and then if we have time and folks are available, we'll stay on for another couple of minutes to answer one or two questions. So if you do have a question, chat it in the chat box. I see one came through already, and we'll get to that in just a minute. So I just wanted to point out, you can see on HealthHIV's website, we do have a variety of programs. Shana and I both mentioned a couple of them, and some of our programs very much focused on sustainability, 3D, and our fiscal health. So I'm going to fly through these slides. Fiscal health focused, obviously, based on the title, more on fiscal sustainability, but also looking at programmatic sustainability as well. So if you're interested in any of these, feel free to contact myself or Shana, and our emails have been in the other slides. I also wanted to point out a new self-paced online series that is launching next month called the BLT. So we're working with organizations to help build their boards of directors skills around strategic planning, financial and fiscal sustainability, and also community engagement and some basics of governance and management. This is a completely self-paced learning series that will be online. So it'll be launching again next month, and we'll be sending out an email, so stay tuned. It's a really exciting offering for your board of directors to help get them engaged and moving around strategic planning to support your organization. We also currently have a free CME professional development program for clinical and allied healthcare providers on LGBT health topics. Again, you can reach that at www.healthlgbt.org. And that offering is available based from our National Coalition for LGBT Health, which is part of HealthHIV. I also wanted to point out our national conference, which we just held this past April 2017, called Synchronicity. Our Synchronicity National Conference will be hosted in 2018, again, in Washington, D.C. So if you're interested in participating in any way, you can contact my colleague, Terrence Calhoun, at terrence@healthhiv.org. And I see Shana's sharing some contact information. So again, if you download the slides, you'll have access to these emails as well. And lastly, if you're interested in joining the coalition, our National Coalition for LGBT Health, you can go to healthlgbt.org. Please follow us on Facebook, and you can contact Benjamin Brooks. He is our LGBT health lead, and he's available at benjamin@healthhiv.org. We are hosting our annual LGBT Health Awareness Week next year at the end of March, so keep that on your calendar as well. We encourage you to submit a webinar evaluation and let us know how we did and how all the presenters did and what additional information you'd like to receive. It's available at surveymonkey.com. So I'm going to hold on this slide, and it looks like we have just one. I'm not sure if that's, I don't know, Eddie, if you want to clarify your question, but it says, how are clients being served? And I'm not sure what the last word is. So if you want to clarify that question, we will ask that to one of our presenters. And I'm going to put our contact information up here. There are no additional questions. We'll go ahead and close out about 10 minutes late. I want to thank all of our fabulous speakers. Oh, client, how are you getting client input? Okay. Emily and Scott, and I believe this was a question for Scott, if you're still there with us, from Eddie. And he was wondering about client input. How are you getting client input, I believe?
Client input from the WACare side or the medical case management side? I see. Yeah.
There we go.
Clients who have really vested themselves in the medical case management process through all these years really were proud of the fact that Lifelong, along with Evergreen and all the other ASOs, were stepping up to the plate, Eddie. And it made clients feel really good, but I can often say that certainly there is a core constituents of clients that are concerned about our venturing into new businesses beyond the HIV positive world. And because of that, and that's a really good question, Eddie, is because right now we're involved in some new strategic planning to do lots more focus groups with the core constituents and our clients across those 12 counties to sit down and say, hey, is this something that we really want to do? And you're right, resistance to change is always one of those things that we have to look out for, but we want to definitely be mindful on the next step and see as to whether or not that this is the next thing that people are interested in.
Great. Awesome. And I see that there's some additional comments and great comments around how folks can be resistant to change. And we know communication at all levels is key throughout a change process. So that's great. And engagement from the board and the community, I see Carmen mentioned as well. So we hope to continue these conversations. They're really great, important conversations around sustainability and around engagement of the community in sustainability efforts as well as leadership. So please stay tuned for our next Sync series webinar and also our ASO leadership webinars. And if you would like to engage beyond participating and have some information you'd like to share, feel free to reach out to me. I'll put our emails up here, and we'd love to hear from you. So with that, we'll close out our webinar for today. I want to thank everybody again, our speakers and the participants, for your engagement. And we hope you all have a great rest of your Thursday. Take care.